This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head. I'm your co-host, Justine Feitelson, here with Dr. Dan Bates. Hello.
Morning, Juz. Hey, I've got something that's, I reckon is one of the most annoying things, is that when someone's late to turn up, like I am,
like you?
They turn up with a coffee. Like, seriously.
It's insult to injury.
It is insult to injury. So anyway,
rude, I know. And it's like,
I am drinking coffee.
And he's taunting me. Yeah.
But it will get me through. So that's like the half-assed excuse to me dragging my ass out of bed late this morning.
It's all good. I could use
the coffee.
Second coffee. Ooh. What'd you order? Do you have a staple?
Almond latte.
Also,
we can get into the why almond milk, because hyperinsulinemia, blah blah.
Coffee
blah.
says
we
a lot
haven't
about
done
somebody.
that episode yet, so anyway.
Well, we kind of started, but yeah, we got into some of the metabolic stuff, but we will get into that a lot more. So today we're going to get into not metabolic stuff, but more regarding dysautonomia. So this is a big, broad topic that affects a lot of people with different disorders in the complex pain space. And there's a lot of reasons that it happens. Today, what we're going to be covering is the overlapping effects, basically, and the symptom management of that overlapping chunk, rather than all the different things that can lead to dysautonomia. So we'll touch on that a bit, but this episode is about managing the consequences and not a discussion of the many, many causes, right, Dan?
I think for clinicians, the thing I like about this kind of helps you see the matrix. So A lot of the time the patient will come in and you're wanting to try and work out what's causing and where the hell's this pain coming from, while the patient's telling you about why they've got lightheadedness and dizziness and they've got all
nausea and weird symptoms,
and they need to wee all the time and all these other symptoms, and so which makes it exceptionally confusing. And if you add a little bit of brain fog into it and you add in
a little bit of storytelling,
like it is like, this is the reason why patients, and particularly chronic pain patients, can be really difficult to actually generate a history out of. And within all this is sort of why I'm like, okay, yeah, it's why it's why they get to pass out. And it's also why I very much take control of a history when I'm trying to work out what's going on. Because, if the patient's sitting there, they haven't been able to sleep for like months, they have got brain fog, so they can't remember the question you just asked, rather than what happened, over the last 3 years of their life. They're dizzy, they need to go to the toilet, and they feel nauseous. Like, seriously, it's hard to generate a history. No, they're not having a great time. So, but this is where looking at dysautonomia, for me, once I hear these symptoms, I'm like, okay, I can see the matrix, the patient's sensitized. I can essentially, I don't ignore them, but from a diagnostic perspective, I pop them into their bucket and then, okay, I'm going to try and sort out this pain here. And then I'll swing back to what are the basics of working at the dysautonomia. And this is Juzz's like superpower. And so we're going to just go through the basics of how you do this. And so I think we might have said particularly in the fatigue episode, this is not the management of POTS, but this is stealing the conservative management of POTS and applying it to a similar set of symptoms, which in this setting probably fits with orthostatic intolerance, and apply those to this environment. So I'm going to shut up and I'm going to let Juz run with how she wants to spiel on this.
Yeah, and I think the last thing that what you said made me think of too is, if you're a patient listening to this, obviously this is to help you manage the symptoms of dysautonomia. But if you're a clinician listening to this, the goal is to be able to see the matrix like Dan and I can now, and identify these symptoms and be able to pick out, okay, patient sensitized and dysautonomia is a piece of it, and these are the affected aspects. And then you can generate a treatment plan instead of just being overwhelmed and frustrated and not liking dealing with these type of patients.
Yeah.
So it gets easier once you can see it.
What goes along with these is sleep disturbance. So have a look at the sleep episodes. Sensory hypersensitivity, look at the sensory hypersensitivity episode. Fatigue, look at the fatigue episode.
It's all the sensitization related.
It's all the sensitization stuff. So just have a look at those episodes if you get the sense
you have
that the
dysautonomia.
If you as a patient have got it, or if you as a clinician all of a sudden go, ooh, I see the matrix.
Sounds
go listen
familiar.
to that podcast.
Yeah. Perfect. So getting into basically what is dysautonomia, right? Dysautonomia is essentially dysfunction of the autonomic nervous system. Like Dan touched on, it often comes alongside all these other buckets of sensitization. And what's tricky about dysautonomia is it affects multiple body systems often, and the symptoms that develop depend on which of those autonomic systems are primarily involved. So it's not the same for everyone, but there's patterns.
Yeah. And I think that the other thing that makes it really complicated as well is that it's a system, and it becomes this two-way process where you might start with central components. So in our model where we think about things, it's a neuroinflammatory model. Particularly, a good example of that is where you've got long COVID. COVID will drive a neuroinflammatory process of the brainstem, and then you get all these symptoms. So that's a central regulator problem. But the autonomic nervous system's got a sensory system and it's got effector systems. And so the effector systems run through your sympathetic and parasympathetic nervous system, and they can be abnormal as well. And because it's got a sensory component, you then get two-way stuff going on. And so the easiest way to think about this, I think, is in the setting of something like, gastrointestinal symptoms. So you get your IBS type symptoms, so nausea, bloating, diarrhea, constipation, intermittent vomiting. And you go on and develop dysbiosis. So you've got abnormal microbiome, which then winds those symptoms up, and now you're away. So now you've got this two-way system.
Off you go.
You go. And, you've got to work it out both at a gastrointestinal level and at a central level, and they both affect each other. So super complicated, difficult to manage. But once you start recognizing that there's multiple components to it, you can start, chipping away at each one of those components.
Yeah, the other thing that makes this complicated is what the autonomic system is comprised of as far as sympathetic and parasympathetic. And when you have diseases like complex regional pain syndrome, where you already have a high outflow sympathetically, or you develop issues from a vagal tone perspective, that can also impact the intensity and the output of these symptoms. So certain diseases, dysautonomia tends to be more common. It's not just with sensitization in general. Other common populations that we see this in, Dan mentioned long COVID already, neurodivergent population with that sensory overlap. This can often develop in POTS patients, Dan's already mentioned as well. And then the other major group is the hypermobility chunk of folks.
The other major group I was thinking about. So they're the major groups, I think, in our population. The other major group is diabetes.
Yes.
So diabetes, you get autonomic neuropathies. And so you get dysfunction of particularly cardiovascular dysfunction, renal dysfunction that takes place with all these things. So common, complex, but once you recognize the symptoms, the matrix starts to sort of lay itself out.
Yeah, and even just with the sympathetic nervous system alone, things that's controlling: pupil constriction, saliva stimulation, airway constriction, heart rate changes, right? Stomach and intestine activity, gallbladder stimulation, glucose release, bladder contraction, sexual function. So if you're having issues in these different systems, think about dysautonomia. That's also kind of an important trigger. Like with certain things, it should trigger think sensitization. Certain things should trigger think dysautonomia. So let's get into main types and presentations.
Yep. Go.
Solid. All right. So the way we've kind of grouped these out are first with orthostatic intolerance. So that is not literally POTS, like Dan mentioned, but it's the POTSy stuff. And similarly as with chronic fatigue syndrome, you can apply what you would do for the actual disease process to orthostatic intolerance itself. So it's just blood flow regulation disorders, right? Symptoms are increase of heart rate, often upon standing, things like fatigue, dizziness, near fainting, lightheadedness. So it's not complete POTS, but it's quite similar.
Yeah. So POTS is an increase in heart rate with essentially a minimal or no decrease in blood pressure.
And that's the key difference, right,
Yeah,
Dan?
that's the key difference. Orthostatic intolerance patients may develop hypotension, so their blood pressure goes down. You stand up, blood pressure goes down, and then your heart rate goes up, which is a normal response to your blood pressure going down. You see that a lot in particularly your early hypermobile patients, where what you've got taking place is not so much a central component where you're getting the heart rate racing, but you are getting dilation of blood vessels and then pooling of blood in effective your legs. So you get decreased return to your brain. The resultant effect is decreased return, heart rate goes up to compensate it. So then you get the tachycardia, you got less cardiac output, that gives you your lightheadedness and dizziness. And so yeah, they're effectively the differences. POTS itself is also like its own disease process and likely has, some autoimmune components to it in some patients.
Yeah. All right. Next bucket, touched on it already a bit, but the gastrointestinal chunk of things. What are the common symptoms? Nausea, vomiting, bloating, right? GI distress, not even due to specific intolerances, just in general. Diarrhea, constipation, just general abdominal pain is very common. And then it can get into things like reflux, other disorders like gastroparesis. Again, when you have sort of too much stretchiness, which you see often in hypermobile population, this one comes along a lot also with complex regional pain syndrome and an overall loss of appetite and difficulty often getting food in because of all of these issues. So if you're struggling with this bucket of stuff, also check out the fatigue episode because we cover a lot from a nutrition perspective that can be applied to, it's hard for me to get food in, it's hard for me to eat large amounts at once, everything makes me feel sick, and how you can kind of slowly scaffold in things that are tolerable.
Nausea is such an interesting...
such a pain.
It's a pain, but it's such an interesting symptom. Like,
Signal.
why do we get nausea when you get sick? Like, what's the advantage of that? I don't know. Anyway, there's got to be some sort of advantage.
Got to be some reason.
We wouldn't have it from an evolutionary perspective, but anyway.
Yeah, and then we'll get into that from a treatment perspective, how you can kind of use anti-nausea meds a little bit more effectively and whatnot. But a lot of this comes down to conservative management and being aware of those things too. All right, other buckets. Those are the two sort of larger ones. And then the other symptoms that we see often are urinary related symptoms. Dan mentioned frequency,
urgency, incomplete emptying.
Nailed it.
A lot of the time you get labeled with interstitial cystitis within that setting. There's a whole stack of other bladder symptoms and conditions that present with those symptoms.
And sometimes this is one that feels awkward to talk about. If you're a patient or you don't mention it, it's a little weird. And so if you're a clinician, ask like with empathy, not like aggressively, but try to pull these things out of a patient because sometimes we don't want to say it because it makes us kind of uncomfortable or we don't think it's important.
Oh, thanks for that tip.
I
just ask. I don't.
Yeah, Dan's not shy anymore.
I'm just like working through the list, and so yeah, maybe I have to recognize that people feel a little bit coy about it.
Well, no, I think it's better to ask. I mean, I think the point is to ask, but just. Yeah, be nice. Sometimes patients don't share.
Be nice stuff. When you ask.
Be nice. Do you have incomplete empty? Yeah, it's not what you say; it's how you say it. All right, Secretomotor. This is the one we're always poking fun at me at because I sweat a little much at times. So it's sweating, difficulty regulating your body temperature, things like dry mouth, obviously when not medication side effect related. This feeling of like really having to try to swallow. Sometimes the swallowing should be an automatic thing we don't think about, and that can become kind of awkward. And then skin, sort of dryness. What would you say skin-wise under secretomotor, Dan? Is there anything that you can think of else? Yeah, just dryness.
Interestingly, you do get dry skin. It's one of the questions within central sensitization inventory. Do you get dry skin? Dry skins can be driven by decreased secretions for your sebaceous cysts, which interestingly, sebaceous cysts are supplied by the sympathetic nervous system. And so you've then got that alteration in sympathetic outflow taking place. Whether it's actually that, I'm not 100% sure, to tell you the truth. So certainly they get parasympathetic outflow as well. So it probably ends up being some sort of balance between sympathetic and parasympathetic outflow that then defines, how much secretion you get from your sebaceous cysts.
And that's a really good point because oftentimes when this is explained or with certain diseases, you hear the issue being just that there's too much sympathetic outflow, but the issue is often actually the interplay and the back and forth between the sympathetic and the parasympathetic changing or being off. So it's not just too much sympathetic, it's that back and forth being altered. And that's actually often the root issue. Yep. Thanks, Dan. That was helpful. All right. Pupillomotor is the next section. So these are symptoms like dry eyes, blurry vision, light sensitivity, impaired pupil response. And this is one that I see often affecting movement and movement patterns as well, because when your eyes are affected, right, the visual information that your brain is taking in is different. And this too can affect the motor output in certain settings. So it's not just, oh, I have annoying dry eyes. This can lead to other things, but even those simpler symptoms can be very annoying. I mean, it's not fun to have blurry vision and things like that. So we'll get into what you can do from a treatment perspective with this. All right. So those are the main types of dysautonomia: orthostatic intolerance, gastrointestinal issues, urinary, secretomotor, pupillomotor. So match those symptoms. Then to
the one that we leave out, and because this is the one everyone gets angsty on talking about, is sexual dysfunction.
Oh, yeah.
And so we do have a sexual dysfunction bucket on the
that's the one patients don't want to share and talk about.
That's the one no one wants to.
And doctors don't want to talk about.
Yeah, no one sort of wants to head that direction. But it's such a major issue because it impacts not only on yourself, self-worth, and then your relationship, that it is really difficult. To be honest, it's something that I probably don't dive into well enough because I don't understand how to manage it well. So maybe I need to pull my socks up and find out who I need to refer that to.
A referral.
Yeah, that's a referral job.
I mean, quality of life, intimacy, relationships. When you talk about what do you lose because of chronic pain, it's a significant one. So there are resources.
I've also wondered how much like painful periods and heavy periods fit into this bucket. I maybe yes, maybe no. I certainly historically they've been thrown into that bucket, particularly with Burkitt syndrome, etc.
Go listen to History of Hysteria.
So they threw all these things into that bucket
because they were very bothered when women had sexual dysfunction, because what you're supposed to do about it is just have more sex. Back in the day.
Back in the day, that was the problem.
That was the problem. Right?
So
it's still a problem.
It wasn't enough sex. Was the problem why you had all these problems,
all these issues? Yeah.
And so the solution is clearly quite obvious. So
and I think if anything, even if we're not getting into treatments for that on this episode, it is something that if we can remove some of the stigma and the discomfort and the awkwardness of talking about, like changing that at least gives you an opportunity to communicate and help yourself instead of feeling like there's something wrong with you or you shouldn't talk about it, because you should, because it is a big part of your life. So
what was interesting about Burkitt? So Burkitt, just for everyone, he was a French physician. He was a French physician that at what hospital was it? Saint Pierre or
something?
Saint somebody's.
Saint Agatha sounds.
I think it was it. Anyway, so he was interesting. What he recognized within this set of, issues is that he noted that the prostitutes that they had had been admitted to the hospital had a whole stack of problems. And he was like, hang on, they're having sex all the time. And the nuns didn't. And they're going, hang on, the nuns aren't having
the nuns are good.
Any problems, but the prostitutes are. I'm not so sure this is about sex. That was one of his observations.
What a smart guy.
And he actually started to go down that maybe this is a trauma issue for some patients. Yeah. And so anyway, that was one of his observations. So
that's funny.
In the 1800s, took a little bit of time to, get it through, but we got there.
We've improved on some treatments at least since then.
Western medicine's kind of getting there.
Speaking of management, should we get into actually dealing with these things?
Yeah. Go. Yep. Orthostatic intolerance.
All right. So we'll kind of go between conservative, and I'll pull out all the medical stuff from Dan that we can with this too. As far as conservative management strategies, we already touched on it. Compression garments for that pooling that you get in the lower extremity. Waist high is really helpful if this is a big issue for you. 20 to 30 or 30 to 40. What is MHG? Millimeters per...
Oh my God, it's millimeters of mercury. It's millimeters of mercury. And please don't tell me we're in a metric imperial problem here. Oh my God, what do you call it in the US?
When I was looking on, when I was buying them on Amazon, it's just, there's like the tightness is what I'm referring to. I don't know where
are you doing it in bars or something in the US?
Maybe.
Oh my God.
I don't know what we're doing. I can't defend anything that does with the metric system.
Yeah, so it's 20 to 40 millimeters of mercury or whatever thing you use in the US. I don't know.
Yeah. And just those are the measurements. Like if you're on Amazon scrolling, one is tighter than the other. And so you can kind of try both. Because if you have sensitization and allodynia and some of these other things with other pathologies, it can be annoying to wear compression. So if it is, choose something slightly looser is the point. But that still gives you some of that feedback. And
oh my God, we got more metric coming. Go.
Okay. Salt intake, 10 grams a day.
Okay, 10 grams a day. It's a bit under a third of an ounce. So just, there we go. Third of an ounce of salt, or and 2 teaspoons for,
I like 2 teaspoons.
For the cooks.
Yeah, exactly. For the bakers in the house. And then with fluids, go higher than that sort of general half your body weight in ounces. For orthostatic intolerance, you want more like 3 liters a day, similarly as with POTS patients.
Which is, who knows how many pints. So
pints. I only think of beer when you say pints. Pints of water, I've never heard that.
What are we in now? So what are we in for you guys? So what are we going to talk ounces of water? Oh my God. Can you guys but please catch up?
Leaders here. Don't talk to me, Dan. This is not my dad. I'm half Hungarian. I'm like the most not ethnocentric American. Okay.
How many ounces is 3 liters of water, please?
How many ounces are in a liter? 32, right? So 3 times 32 would be 96.
96 ounces.
This is 36. This is a liter. So this size, 3 of them.
Okay.
For the visual people. All right. And then avoid doing what I am doing right now. Prolonged sitting and standing, also not great. So try to change positions. From a movement perspective, it can be hard to do standing exercises. So one thing we'll touch on is don't do them in that position if it makes you dizzy or faint or those other things. You can do things in a quadruped, seated. There's a lot of different ways that you can do stuff that you would do standing and adapt it so that you don't trigger more of those symptoms. Water workouts and movement are really, really good when you have this going on, or in different, prone or lying down positions. So don't feel like you can't do exercise just because standing is a bit triggering. It's a big one. Medical wise?
Yeah, interestingly, so my colleagues, I personally don't dip into this because I don't really prescribe these medications, but my colleagues that look after my patients with, POTS/orthostatic intolerance, it's kind of interesting watching what they're doing. Essentially, they're just managing the same these days. So it starts with first line therapy, as we've just gone through, and then they're moving into, midodrine, fludrocortisone, pyristigmine, ivermectin, and then, if they're trying to control heart rate, they use propranolol.
Right. That's what I use. That's what I used for when I had worse orthostatic intolerance because of allostatic load, et cetera. It was this very high heart rate, just standing.
Yeah. So the heart rate piece is interesting in that, that's probably, I think, where you've got true POTS. Because I had all these patients coming to see me and I'm looking at them going, your blood pressure is going down. Why are you putting them on propranolol, which lowers their blood pressure?
Lowers their blood pressure, yeah.
And so I think there's I was seeing this group of patients to start with that were probably orthostatic intolerance with secondary tachycardia, and the people that were managing them were missing the fact that they were actually dropping their blood pressure instead of really managing the tachycardia. Those patients with true POTS that have got tachycardia with no real drop in blood pressure, well, that makes sense to manage them with propranolol because
you're not negatively affecting something else.
Yeah. So anyway, then there's a large number of second line therapies, which, once again, I just refer out to my friendly neighborhood cardiologist or general physician for. Shout out to Edmund Song and Chris O'Callaghan.
Thanks, guys.
A fantastic job. And third line treatment is then IV saline, which interestingly a patient asked me about last night.
I've had a fair amount of people do this, sort of not all the time, but when things get a little more hairy.
It was interesting. She actually noted it as she'd come to me and had noted it out of something else, actually. She said she felt fantastic for a couple of weeks after just a liter of saline, which I actually have no understanding how that lasts for so many weeks because it's just normal saline.
When I had the terrible period of GI stuff where I couldn't eat or drink and got down to 110-ish pounds, that's when I was doing IV saline because I was so dehydrated. So if you're super dehydrated, it's a kind of a rescue thing. Ideally, don't get super dehydrated and then try to help yourself with saline. But it is a helpful tool for some of those POTSy people.
Interesting. Anyway, moving on. GIT
All right.
issues.
GIT. So, conservative wise, this is again kind of the basics, so to speak. Diet is tricky because it does get very individualized. And the way I look at it is almost like a pyramid where everybody's got to do the basic general stuff, obviously taking, allergies or intolerances into account. And then once you master these underlying things, you can get more and more individualized and narrow or creative in ways in what type of diets you try or what things you maybe eliminate that are triggering. But in general, you need a healthy, varied diet, low in processed foods, be smart about meal timing, just like we talked about in the fatigue nutrition episode. Don't get super behind on food and not eat till late in the day because that does not help lightheadedness, dizziness, right? Not feeling good. Eliminate trigger foods that that you have a response to. And then some more common ones that I kind of see across the board are things like caffeine, alcohol, high fat or spicy food, especially if you have certain gut issues, aspartame, sugar, especially refined sugar being too high, and then dairy and gluten, which are the more common true general allergies that I see in this population.
So if it's fun, don't eat it.
If it's a good time, don't ingest it.
My son, during the period of time that he had salicylate intolerance.
Debbie Downer episode.
Oh my God, I'm so scarred from that. Salicylate intolerance. I think the easiest way to manage a salicylate intolerance, if it tastes good, spit it out. Like that's it. So you just like, oh my God.
Out.
But yeah, I think they're trying to work through these things and down regulate how irritated your tummy is so you can sort of, and seeing that I hope to see this as a two-way thing. So like you've had some central neuroinflammatory process that's wound everything up at a brainstem level. You then get your secondary hypersensitivity at a gastrointestinal system level.
Right.
Et cetera, et cetera.
And the gut-brain axis now is a much a bigger hot topic. Yeah.
And so, but then being able to wind down both of these things doesn't mean that there's no caffeine forever. It just means that you've got to go through this process to start with. And I think the other thing that within this, there are other conditions that drive the symptoms. So, Juz is about to mention about small intestine bacterial overgrowth. So looking and treating for that, that's very important in engaging with a gastroenterologist. Also engaging with the gastroenterologist around this to go through get the colonoscopy, get the gastroscopy, look for those things. In that setting, mast cell activation syndrome in this environment, one of the questions I am looking for in patients is, do you get pain post-eating? And so if you're getting pain post-eating and you've got your list of mast cell activation syndromes, symptoms, then, okay, I'm thinking about we need to try and treat you actively with some antihistamines to try and get some of those. So once again, it's this, yes, this is the set of symptoms, but what's driving these symptoms is the underlying, major question.
And it's the same thing as with fatigue, right? As the patient, you have to do all these non-negotiable basics kind of to give yourself a shot, managing almost the consequences of that. But then you still need a referral or a specialist to help diagnose and do the things to affect the thing that is potentially driving it. So
and
you have to figure
stuff.
those things out, right? Whether it's SIBO or C. diff, and then when you have potentially hypermobility in the mix and MCAS, things like the FODMAP diet, et cetera, you can evaluate, with more appropriately and go, is this for me? Is this something that I should look at further individually on my diet now that I've got meal quality and timing, my protein is normal, I know what to source and how, and then you can match that intervention to a more individualized issue.
Yeah. And I think
same thing with gastroparesis, right? Or different gut issues where you have trouble swallowing or you have to make food softer. So that's what I mean by you have the basics and then you got to narrow it down.
And I think that in this setting, understanding, these components of the symptoms that you're experiencing allows you to then go and see a gastroenterologist and go, I want you to help me with this stuff. Like, I've got all this other stuff going on, but can you help me with this stuff? Like, tick off that I've got nothing bad, and then give me some guidance around how do I manage this symptom set while I'm calming everything else down and make sure that I don't have anything I'm going to die from. So that's how you use the gastroenterologist. So.
Yeah. And I love the way that you sort of role played that, because again, as the patient, you're the boss, you're the employer, and you have the ownership of, you have to seek out people that can help you. And be proactive in that. Don't just settle for, oh, I have nausea all the time and it's a part of pain. Well, it is, but also what else can you do?
What else can
All
you
right.
do?
Are there any medications, Dan, that you want to touch on from a medical perspective with some of the gut stuff, and particularly with anti-nausea? I talk a lot about using those sort of prophylactically or intentionally to be able to consume more food in certain feeding windows, not just after the fact once it's too late. But
You know
outside
what?
of
I don't ask.
anti-nausea.
I don't really ask. Maybe I should ask more.
Yeah.
In that, yeah, I think that a lot of the time when I get into complicated eating issues, like I've got some simple strategies around eating. I think that when I start getting into these more complicated areas where I've got nausea interacting with, with food intolerances,
Yeah.
with particularly if you add in some autism spectrum disorder and a bit of hyperinsulinemia, like, okay, so now this is super complicated. And
Right.
so then I actually engage with some dietitians in that setting.
Right.
I a lot of the time use the guys at Active Health who are in Melbourne. They also see people online. So they are a super set of clinicians that really understand complicated patients. And
That's a good resource.
like with everybody else, it takes forever to get in to see them, but it's, they're definitely worth the wait. So I'm okay, this is outside my bag. This is a problem. You need to see these guys. So I manage it with referral rather than 100% of let's sit down and I'll give you some, Maxilon and Stematol and
right. Because then again, it's harder to get to the root of why it's even happening. Whereas a gastrointestinal doctor or dietitian can better.
That's their bag.
Yep.
That's
exactly.
their skill base.
Yep. All right.
If you can move it and it hurts, I can sort that out.
That's Dan. It's a back, neck, and joint. Come and see me. It doesn't say back, neck, joint, and complicated nutrition.com website.
No, it does not say that.
I think does it say that in mine? It doesn't say that in mine.
It does say in yours. You actually literally sell that stuff. So I
literally call you
literally
guys
your
to
job.
me.
That's the other person I send people to. You.
Exactly. They got to go back and forth. So that is the GIT bucket of stuff. And if you're curious about some of these other diets, right, look up FODMAP. You can look up what people do for SIBO. Think about those triggers and listen again to the nutrition episode under the umbrella of fatigue, where we get into more of the basics, as well as the basics of conservative pain management, where we also touch on some of these more first line non-negotiable nutrition things that can help. All right.
Yep.
Other systems that we touched on earlier and how we can kind of manage those. Again, some are a little bit trickier than others, but we will give it a stab. So in general, the urinary bucket of stuff is tough to treat, like we said. And sometimes the way that I can help is to try to avoid harm or, waste of time or money. And so do at least avoid misleading supplements and things that kind of make it seem like they will help this and they don't, because they're not getting at the mechanism of why it's happening. It's kind of all I can.
And I know everyone's asking what's the misleading supplements, but
well, there's just general.
We're not going to get sued, so you have to ask Juz directly.
You gotta send me an email. That's it. Yep. And is there anything from a medical system perspective, Dan, for that urinary bucket or is it just in general? You hope a stellate ganglion.
Once again, I'm seeing that as you've got dominant urinary symptoms. I need to involve a urologist because it gets outside my skill base. And I think that from a doctor perspective, it's about being able to go, okay, I see this is what your problem is. Exactly. You now need this person.
Right. It's not solving the whole problem yourself. That's not possible.
Yeah.
But you got to see it.
Yeah. So as soon as I see it, that's a referral process. Interestingly, it's, when I'm going through my history, I'm looking for what's the dominant driver, like set of symptoms, and urinary symptoms aren't regularly dominant, but when they really drive.
Yeah.
Things. It's sort of like it's similar to, balance issues. So when balance issues are there, they are really, really tough to deal with.
Yeah.
And I think that urinary symptoms sit in the same bucket, and that's why you need expertise in that area. So I send to the expertise.
Yeah, I mean, and this is the ongoing challenge with complex patients. So when you have these different things going on, is there are a lot of referrals involved, and you do need a lot of specialists, because one pain doctor can't cover all this. But if you are a pain doctor, the goal, just like Dan is an example of, is being able to see it, identify it, because the patients don't have this information necessarily when they're walking in the door. And at least if you can help them, or that understanding, they have the information, but at least if you can then help them sort it out, and then they can take ownership over, okay, these are the pieces I control and impact. These are the pieces you can help me with. And then these are the pieces that are an outsource. And you start to piece your team together, like we've talked about. And how do you build your team? And how do you become the boss of your own care team? You have to see what you have to deal with and then address all the different pieces.
Yep.
So next bucket of things that you got to deal with is the sympathetic overdrive. And this is very common, again, in CRPS patients once you have sensitization, hypermobility. And this is a common one that I look at from a mindfulness and diaphragmatic breathing perspective. So you got to integrate those tools that help you kind of downregulate, manage your nervous system better, and not just sort of be at the mercy of that being out of control, because that then really fuels and adds to the fire of things like CRPS, where you don't have that margin for error. So breathing and being more grounded isn't going to bring you down, 3 or 4 pain points, but it's going to help things not escalate at times when they otherwise would, and help you sort of filter and cope in a way that makes it less overwhelming and intense, because then you're not adding anxiety and high heart rate and all this stuff becoming this, driver in and of itself practically.
Yeah. From a medical perspective, there is actually taking out like all your anti-anxiety medications, which these days are dominantly SSRIs. And certainly if we're going to talk about medications in that setting, I avoid benzodiazepines like the plague in that setting, because they're so addictive. But the other thing that sits in here is also stellate ganglion blocks. So the stellate ganglion is a collection of nerves that sit up at in your neck, basically, just at the front part of your neck. And you get a lot of the sympathetic overdrive comes from essentially hypersensitivity of these nerves. So there is data around using sympathetic ganglion blocks within PTSD. And so a lot of that came out of the military literature. And they can be quite effective with decreasing these symptoms. I think that picking the patient is really important, though. And I think you really have to pick that patient with PTSD or with, some overwhelming anxiety.
Issues.
Because the data, if you dig into the PTSD literature, pretty much shows that sympathetic ganglion blocks do decrease anxiety.
Right.
However, I found that these can be a bit hit and miss in these patients, which I think comes back to what you were referring to before, which is it ends up being this balance between sympathetic and parasympathetic activity, and you end up blocking the sympathetic ganglion and you put it all out of whack. And your patient can actually get worse. I can remember one, I think I've got 2 in my head, that we've done sympathetic ganglion blocks and they've got worse afterwards. And I think we've really disturbed the balance in that setting. But that said, I've got a bunch of patients that have got PTSD and severe anxiety that, their wives call and go, he needs another one.
Dad, please stab him again.
Can you do it? And it's interesting. They all say, "Oh yeah, my family tell me I need another one." So,
and I've had 2, at least 2 CRPS patients who have also done this, and same bucket profile, where history, right, of PTSD, high anxiety, high hypervigilance, not even pain behavior in the sense that they're like scared and not trying. It's just they're very aware, almost too aware of themselves. Like it's a good quality that is taken too far. Mm-hmm. And so it's a certain personality too, that I see this kind of being helpful in a calming, sort of down regulating way. And they have had good outcomes with it. So it's something to think about if you're struggling with that and you have some of these specific disease processes that change that back and forth.
Yeah. And I think you're about to mention as well, sort of stellate ganglion blocks within the Secretomotor group. Like there is data within that environment where they've showed to be effective.
Do I need to get one? Oh, I'm doing pretty good today.
Don't show us your pits.
There's like 7 people that watch on YouTube.
Right. So to those 7 people, which I know one of them,
I probably know the other 6.
I apologize.
But so stellate ganglion can be a little bit of a double whammy. So if you have the sympathetic overdrive, high anxiety, you're having trouble regulating your body temperature, which comes a lot with that, and increased sweating. This can be a kind of kill 2 birds with 1 stone tool. All right. Anything else on that?
No, move on.
Sweet. Okay. As far as secretomotor, special deodorants, right? There's ones that are UV more antiperspirant versus just the deodorant. Yes, that can have weird stuff in it, but if it helps you sweat less, upside downside calculation for you to make. There's not a whole lot outside of that I can think of, other than what we touched on in the past too, as far as just being able to regulate your body temperature a little better with different layers of clothes, having different options to go to. If you have CRPS and an affected limb is really, really hot at night, putting a fan on that part of your body so that it kind of cools it and keeps you from getting real wound up and even hotter. And there's just this uncomfortable overall situation. So it's kind of just managing yourself from a layer perspective. It's not a whole lot else I can offer.
No, hyperhidrosis is super hard to manage. Like I like
very annoying.
It's very annoying. It's hard to manage. So
yeah,
it's pretty crappy.
Let's get a good deodorant that you like. Go from there. All right. Pupillomotor. Oh, Dan, it's your favorite.
FL41 glasses.
That's it, baby.
Bring it on. I had some massive winners with the FL41 glasses.
It's like a baby stellate ganglion block that just kind of just like down regulates, filters out some of that angst. Yeah, some of that annoying, bright lights. That's basically what this is getting at from a pupillomotor perspective. And then, like we talked about with things like blurry vision, pupil response, some things around eye exercises can help with that, trying to increase your visual field, working on tracking convergence. Our eyes have muscles too. And if you don't use them or you have discrepancies side to side, there are things that can help with that. Outside of that, drops for dry eyes are common and helpful. And those are the main things that I use for pupillomotor issues.
Okay, next.
All right. So I already touched on this a little bit around movement with dysautonomia, but basically avoid it in standing positions if you need to. There's a lot of things you can do seated as far as hip stability. You can work on toe extension with a yoga block. You can work on calf raises. You can work on hinging. Lying down, you can work on clamshells, abduction, even adduction, ankle control, side lying, right? Leg raises. There's a lot you can do from a pelvic stabilization perspective. So don't feel like, again, just because you can't stand and move around or run as much as you could, that there's nothing you can work on, especially if you're hypermobile, and stability is a big issue. So even a lot of people that don't have dysautonomia, we're doing a bunch of stuff in these other positions, and it helps them improve that and have less widespread pain adding to everything. And then the other position is in a quadruped, right? Just on your hands and knees, hinging, rotation, right? Bird dog, cat cow. If you've been in PT, some of these are probably familiar sounding. So it's just like everything else. Do the best with what you can and don't, beat yourself up for what you can't. And over time, you can become maybe more tolerant to standing and doing things in a more vigorous way.
So what are your big ones? So if you want to really try and move the dial.
Move the dial.
You're like, okay, that's all good, Jazz. I've got, a million symptoms.
I got all the stuff. Yeah.
Where do you start? So what are your dial movers?
Yeah.
How do you get things going?
Yeah, the biggest things that I look at first are also the things that are in ways easiest to implement and also very helpful. So hit your watermarks, right? The 3 liters a day, use a water bottle, track your intake, or 96 ounces, right? So if you're kind of in the orthostatic-y, like I'm a little dizzy, I'm a little heart ratey, use the fluids, add electrolytes, right? Use salts, 10 grams, i.e. 2 tablespoons. You can experiment with different brands of electrolytes, just get ones that don't have a bunch of extra sugar and shit in them. And then from a movement perspective, changing positions frequently. And really, if you have GIT bucket of stuff, which is very, very common in this, along with that sort of orthostatic intolerance response, is looking at your diet and improving the quality of it. Smaller, more frequent meals, depending on what you have going on GI wise, work around your nausea, see if you can find any patterns, right? Open up eating windows if you do use anti-nausea medications intentionally and take advantage of when you feel better, and then individualize your diet as needed further, depending on specific drivers. And like we talked about, refer if you need someone else to help you in addition. But movement, diet, fluid/salt are the biggest, most common ones. And then when you have those specific, my eyes are dry, or, I have this other issue, or, I'm sensitive to light, right? Use those other specific, smaller interventions. That's kind of how I usually look at it. Because it depends what you got, right? So again, it's matching the symptoms with the system affected with then the conservative management strategies for that type of stuff.
Yeah. And look, and the other important thing is this is what Jazz does. So she runs Base Camp.
Link it down.
So if you are interested in this stuff, go to our website. So Resilient Warrior Coaching LLC. Don't forget the LLC.
Nailed it. I know. I was so annoyed I had to add that. It was
And
taken.
have a look at when she's got programs coming up. Join in. She runs a fantastic program that helps take you through all this stuff and allows you then to individualize what you need, and then gives you a very strong sense of the basics, and then when you need to reach out to that specialist advice.
Right.
So don't forget to look at Jazz's website. And
thank you. Yeah, because it helps the specialists and the other people then do their job best, because if you don't have these underlying pieces in order, it's just like with medications. It's hard for them to be as effective then as they could be. So thank you, Dan. Yeah.
And and just from sitting from the specialist seat, if you walk in, you go,
right,
hey, I've done this, and this. My question is this the right diagnosis? And, do I need, these next steps? Oh my God, bring that on. And it's like,
right. It's like doctors will love you if you're that type of patient, as opposed to, you go to the doctor, you're so excited for your consult. You waited 3 months, you finally arrive. And then it's like, well, I haven't done all this stuff. And so then the doctor is not going to be able to help you at with the thing you really want them to help you with, because they also will ideally want you to have addressed or looked at some of these underlying things first. And then you lost time.
Absolutely. And I'm going to tell you, every doctor does not want to tell you to drink 3 liters of water.
Right. I will take one for the team.
That's it. We're past the drink lots of water and
please
get
God,
some sugar in.
Yeah.
Get the salt in. We're past that. We are on to let's get on and manage this.
I harp on and handle that so the doctors are happy. I'll take one for the team. Yeah, and all the stuff we talked about in the fatigue nutrition episode as well, that's the type of stuff that we also cover in base camp. So every one of these basically buckets of sensitization related symptoms we go through week to week and integrate all the conservative management stuff for. And then what you have left, go see your friendly neighborhood Dan.
Perfect.
All right. Solid. Thanks a lot, guys. We appreciate you listening, and we will see you on the next episode of It's Not in Your Head. Thanks, Dan.
Thanks, Jazz. Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.